Hello everyone, this is Dr. Garima Sachdeva, and today we'll be covering various guidelines related to abortion, pregnancy of unknown location and viability, and recurrent pregnancy loss. So stay tuned, you would definitely find.
So first one is the abortion care, the NICE guideline. Second is NICE guideline on miscarriage. Then pregnancy of unknown location TOG, and then RPL we have a GTG. So all these we'll be covering today. Okay.
Okay.
So like we have clauses for abortion in India, for UK also they have clauses. So which are quite different from Indian one. So they have how, like we have an I and C form. So they also have two forms. They have HSA 1 form and HSA 2 form. HSA 1 is certificate of opinion. So see, in according to Indian thing, like the older law said that up to 12 weeks.
Ma'am, not clear, ma'am.
What is not clear? Hello? Yeah, Dr. Gauri, what is not clear?
Audio.
Still it is not clear.
Now it's okay.
Now it's okay. Okay, fine. So see, abortion clauses like for Indian abort like MTP Act, which like the previous act we had in 1971, which was recently amended in 2021. So previously it was like up to 12 weeks, one doctor opinion is required, and up to like from 12 to 22 doctors. Now it has changed that up to 21 doctor opinion is enough. So, but according to UK law, it is different. They say that at whatever time you're doing abortion, you require opinion of two doctors. However, the termination can be done by one doctor. Okay.
Okay, ma'am.
And they have two forms. So they have this HSA 1 and HSA 2 form. So it is a certificate of opinion where the doctor give the clause in which that particular type of abortion fits in. I'll be telling about the various clauses shortly. And it has to be given by two doctors, and the records have to be maintained for 3 years. Okay, HSA 2 is when you are doing abortion in an emergency, where only one doctor opinion is enough, and again, this record has to be maintained for 3 years. Okay,
Okay.
so abortion is legal in Britain if two doctors decide in good faith that in relation to a particular pregnancy, one or more of the grounds specified in the Abortion Act are met. Okay, so they have given A to F clauses. So the first one clause is when the continuation of pregnancy involves the risk to the life of pregnant female. Okay, so here there is risk to the life. This is also one of the clause in Indian one, but you have to remember that what A stands for, what B stands for, because questions are asked on this. You get MCQs and SBAs and EMQs on this. Then clause B is termination is necessary if there is to prevent grave permanent injury to the physical mental health to the pregnant female. Okay, so B, like sometimes they can give you these examples: pregnancy due to rape or any major medical problem. It will fall under clause B, where there is grave injury. Okay,
Okay.
okay, that is B. Then we have C and D. C and D, A and B, abortion can be done at any time in pregnancy if there is risk to the life, or if there is risk to cause grave permanent physical mental injury to the mother. So you can do it anytime. They have not specified the time here. C and D, they have specified the time. Up to 24 weeks only we can do. For C and D, we can do it only up to 24 weeks. And C is when there is injury. There is no grave here. So there is some injury to the physical mental health of the pregnant female. Okay, so it is not grave. It is not affecting her life. Okay. Then D is when there is physical or mental, like there is risk of injury to the physical mental health of existing children of the family of the pregnant female. This is also up to 24th weeks. Okay, so C and D you should remember is the only two clauses where it is
Ma'am,
up to
C is for the pregnant women and D is
other children of the family. Like suppose they have already two children, she's not
okay.
financially sound, bring up them. So like
Okay.
that.
Okay.
So that would be D. Then E is if there is substantial risk that the child, if born, will have some physical, mental abnormalities or as to be seriously handicapped. So in this E, they can give like excessive, there is excessive bleeding, so that can fall in E clause. Okay. Then F and G, you should remember these are emergency. When you're doing it in an emergency. So F is to save the life of the pregnant female in emergency, and G is to prevent grave physical mental injury to the life of to the health of pregnant female. Then there is in order to prevent grave permanent injury to the physical mental health of the pregnant female. Okay, so they are similar to A and B clause, but in this you're doing it in the emergency where you cannot wait. Okay, so then they fall in F and G. Okay.
Here there is no upper limit of gestational age. It
See,
can
for
be.
C and D, we have upper limit of gestation age. Okay, and for emergency, I told you only one doctor opinion is enough when you're doing it in emergency. Otherwise, you require two doctors' opinion.
Okay.
Okay, so this was about the clauses. Then, what antibiotic prophylaxis you should give to the patient, whether you should give it to all or not. So, if you're doing a medical abortion, you need not give any antibiotic prophylaxis. You have to give it only when you're planning for a surgical abortion. And this question comes: what should you give for surgical abortion? You have to give doxy 100 mg PD for 3 days. Okay.
Okay.
And when using metronidazole for antibiotic prophylaxis in medical or surgical abortion, do not offer it in combination with another broad spectrum antibiotic. So, and as an alternative, you can use first line is always doxy 100 BD for 3 days. You can also offer metronidazole, but if you're giving it, you should give it alone and not combine with other antibiotics. Okay. And then how do you proceed? Like what are the dosages and how can you give? So up to 9+6 if you are doing a medical abortion. Then obviously you have to give Mifi followed by misoprostol. Okay, so up to 10 weeks you can give it, and in the next slide I'll be telling you can give it in the gap of 24 to 48 hours, Mifi followed by misoprostol. However, in this you can give them an option up to 9+6, you can give them the option of expulsion at home. Okay, and misoprostol also can be given at home, or you can give it in the hospital or clinic. So here misoprostol also can be given at home, and expulsion can be allowed at home up to 9+6 weeks. Okay, once she reaches 10 weeks, you can allow for expulsion at home, but misoprostol should be given in clinic or hospital only. Okay.
Okay.
So this was about the gestation, and then up to 10 weeks and including 10 weeks, you have to give like Mifi followed by Meso 24 to 48 hours apart. Like abortion up to and including 9 weeks, you can also give them a choice of taking Mifi Meso together, but you have to explain them that if you give them together without this 24 to 48 hours gap, the risk of ongoing pregnancy may be higher, and it may increase with gestation. It may take longer for bleeding and pain to start. Okay. So ideally, you should give it at a gap of 24 to 48 hours. However, if the patient doesn't want to come again and she wants to take it together, you should explain them that there is a risk that the pregnancy might continue. Ongoing pregnancy can be there despite taking tablets, and bleeding can be longer, and bleeding and pain might take longer to start. Okay.
When do we say that?
Sorry.
When do we say that?
When do we say what?
No, no, no. I don't get it, ma'am. Can you please say
Yes.
this again?
Yes, I'll just repeat it. So ideally, like when you give Mifi, how do you do MTP here in India? Also, we give mifepristone 200 mg, and then after 48 hours, we usually call them for misoprostol. So for
Okay.
them also, it is the same thing. You have to give mifepristone, and then
Mm.
after 24 to 48 hours, you call them for misoprostol.
Okay. Mm.
Okay,
Mm.
but if the suppose you can also give them up to and including 9 weeks, you can also give them an option of taking both of them together. But
Oh. Mm.
if they don't want to come again and again,
Okay.
then
Okay.
But simultaneously you should also explain them that there is a risk that there can be failure of this NTP and pregnancy can continue. There can be risk of ongoing pregnancy.
Okay.
And
And
it,
in this case, mifepristone they are taking orally, so vaginal misoprostol only.
yeah, vaginal misoprostol only. It is
Okay.
vaginal misoprostol. Okay.
Okay.
And it may take
So
longer
this
for
is
the,
upon a patient's request.
yes. No,
Only
you can
upon
also
patient's
offer
request.
from your end also. You can offer, but you should, when once you're offering, you should explain that this is also an option that we can
Okay.
give you both together, but these are the consequences of that.
Okay.
Okay. Then between 10 and 23 plus 6 weeks, you have to give Mifi and Misoprostol 36 to 48 hours. There we were giving it 24 to 48 hours. Here we have to give it 36 to 48 hours after Mifepristone. You have to give Misoprostol. And what should be the dose? So what happens as the gestation increases, the sensitivity of the receptors to prostaglandin of the uterus increases. So then the dose of misoprostol keeps on decreasing. The required dose keeps on decreasing. So between 10 to 23 plus 6 weeks, how much dose you give? You give either 800 microgram vaginally or 600 microgram sublingually. After that, you give 400 microgram every 3 hours until the patient expects. Okay, which can be either vaginal, sublingual, or buccal. Understood?
Okay.
Then between 24 and 25 weeks, the dose will decrease here. Here you have to give 400 microgram every 3 hourly until delivery. So only 400. Here we are not giving that bolus of 800 microgram.
So it is
Then
not every 4 hours, every 3 hours only.
every 3 hours only. Okay.
Mm.
So this was also every 3 hours. Then here the duration also increases and the dose also decreases. So 25 to 28, you give only 200 microgram every 4 hours until delivery. Okay, and after 28 weeks, you give 200 milligram Mifi followed by 100. Here the dose further decreases, 100 microgram, and the duration also increases every 6 hours until delivery. Understood? So these doses keeps on varying based on the gestation.
Okay.
Okay. Then for cervical priming, what you should use. So up to 13 plus 6 weeks, you can either use 400 microgram sublingual misoprostol. This is for surgical abortion. When you are planning for a surgical abortion, you have to soften and open the os. So for that, you do cervical priming. So for that, you give up to 13 plus 6, you give 400 microgram sublingual misoprostol 1 hour prior to the procedure or vaginal 3 hours prior to the procedure. Okay, if misoprostol cannot be used, then you can use other alternatives like 200 mg oral mifepristone 24 to 48 hours before the abortion. Okay,
Okay.
then this was up to 13 weeks. Then from 14 to 16 weeks, like you can use osmotic dilators, or you can use vaginal or sublingual misoprostol, or you can use 200 mg mifepristone given the day before the abortion. So it has to be given a day prior to the abortion. Then between 16 and 19 weeks, you can use any of these, like the same thing. But mifepristone is not an option here. Osmotic dilators, vaginal or sublingual misoprostol. Between 19 to 23 plus 6, you have to give a combination of osmotic dilators or and mifepristone 200 mg. Okay.
Okay.
So this was about the abortion guideline. Now coming over to NICE guidelines for miscarriage and pregnancy of unknown location. How do you manage it? The stop. So see, you should inform the women that the diagnosis of miscarriage using one ultrasound cannot be guaranteed to be 100% accurate. So like if there is a like there is a missed abortion, if you're not able to see the heartbeat, or if you're not able to see the GSAC, okay, if you're not able to see the FHR, so before commenting on whether it's a missed miscarriage, you also always have to do a follow-up scan. So this you should tell the patient. And how do you do the follow-up scan? Simple thing you should remember, if you're using like transvaginal scan, then you do a repeat scan after 7 days, and if you're doing a trans abdominal scan, you have to do a repeat scan after 14 days. Okay, that is one thing that you have to remember. Okay. And if this, ideally, if the CRL is more than 7, FHR should be visible. Okay, so if the, how do you make out, like how do you follow up? If you're doing a scan on the vagina, you're doing a vaginal scan, you see a CRL and it measures 7 mm, less than 7 mm, like 6 mm, but FHR is absent. So then what do? You ask them to repeat, because it's a vaginal scan, you ask them to repeat after 7 days. Okay. Then if CRL is more than equal to 7 mm, where FHR should ideally be present, then you have two options. Either you ask them to repeat a scan after 7 days, or you seek a second opinion to, if you want to directly go for miscarriage, like surgical evacuation. Understood? Or like you like if you want to declare. So in the options, if they give you that like these questions are asked in your exam in the form of SBAs or EMQs, so they can give you a question like a patient present to you in the OPD with spotting, or maybe like for a general examination, and you do a scan, you do a vaginal scan, you find that CRL is 8 mm and FHR is absent. So what should be the next thing you should do? So if they give you an option, like if you have to choose between the two, repeat scan after 7 days or seek a second advice, then always choose repeat scan after 7 days. However, if they give the option that you can do anything or any of the above, so then it should be any of the above. Understood?
Okay.
Yeah. So these types of questions are asked and have been asked previously. And then for if trans-abdominal scan, then any CRL, FHR absent, you have to repeat scan after 14 days. Okay, for trans-abdominal 14 days, trans-vaginal 7 days, you should remember. Okay.
Okay.
So even with that much, if you remember, that will be enough. Transvaginal, if ideally with GSAC more than 25 mm, you should be able to see the fetal pole. But if GSAC is less than 25 mm, you're not seeing a fetal pole, you repeat scan in 7 days. If it is more than equal to 25 mm, no fetal pole, you have two options. Either you repeat scan in 7 days or you seek a second opinion. Okay. Trans-abdominal scan, same thing. Any GSAC, no fetal pole, any size of GSAC, no fetal pole, you repeat scan after 14 days. Understood?
Okay. So there is no specific CRL measurement for TAS.
Yes. So
Trans-abdominal.
for everything, you should have to say you will repeat scan after 14 days. In fact, for TAS also, if you have both the options, you
Hmm.
better choose this thing. Repeat scan after 7 days. That
Hmm.
will be a better option if you have to choose between the two. But if you have an option of like both of the above, then it will be both of the above. Sometimes they don't give this in option, repeat scan after 7 days, then it will be seek a second opinion.
Okay.
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 And then suppose like if it's a miscarriage you have diagnosed, then how do you manage? So you can, the first line management is always you should tell them that they have to like just observe for 7 to 14 days. It's a first line management. Okay, after you have confirmed the diagnosis of miscarriage, confirmed by two scans. If it was TDS, then one scan, like two scans 7 days apart. If it was TAS, then two scans 14 days apart. Okay.
Okay.
So once you have confirmed, the first line management is you ask them to just observe for 7 to 14 days, because mostly for these people the bleeding usually starts. And when will you explore options other than expectant management? If you feel that the female is at increased risk of hemorrhage, like bleeding, if she's in late first trimester where bleeding can be more, or if she had previous any traumatic or adverse event with pregnancy like stillbirth, miscarriage, APH, so she can be in depression, so you don't want to prolong it. Or if she is at increased risk from effects of hemorrhage, for example, if she has coagulopathy or is unable to have a blood transfusion, then also you will not delay. Or if there is an infection, so these are the conditions where you will not do expectant management. You will choose an option other than expectant management, like medical management. You'll give mifemezo, or sorry, misoprostol. For missed miscarriage, you don't give mifepristone. I'll be telling you that in the next slide.
Okay.
Okay. So, like once everything is clear, like the bleeding also stops, then what you do follow up with a UPT after 3 weeks. Okay. Ideally, that UPT after 3 weeks should be negative. In case it comes out to be positive, then you have to take a second opinion. Okay, so if the resolution of the bleeding and pain indicates that the miscarriage is completed during 7 to 14 days of expectant management, so then you advise them to have a urine pregnancy test after 3 weeks and to return to the individualized care if it is positive. They have to return back if it is positive. Okay.
Okay.
So this was about expected management, which is the first line management. Then for medical management, for missed miscarriage, what all you can give? Like I was telling you, for MTP, you give combination of Mifi and misoprostol. But for missed miscarriage, you do not give mifepristone. Okay. So for
Okay.
missed or incomplete abortion, you don't give mifepristone. You rather just give a single dose of 800 microgram of misoprostol and advise the women that if bleeding has not started 24 hours after the treatment, she should contact her healthcare professional. And for incomplete miscarriage, you give a 600 microgram. Okay, so for missed, you give 800 microgram, and for incomplete, you give 600 microgram. However, you can also use 800 microgram. Okay. And in this also, like expectant management, once the bleeding, everything is sorted, you ask them to repeat a urine pregnancy test after 3 weeks and it should be negative. In case it is positive, they have to return for review. Understood?
Okay.
Then the third line management is surgical management. So where clinically appropriate of a women miscarriage, like failed, if it is a failed medical miscarriage, then there is risk of bleeding because with medical the bleeding is more, you go for surgical option. And what all surgical option you have? A manual vacuum aspiration under local anesthesia in an outpatient or clinic setting, and surgical management you can do also in a theater under GA. Okay.
Okay.
So this was about how do you manage NTP and abortion. Then about the anti-D prophylaxis. So you have to give them anti-D at a dose of 250 international units or 50 microgram to all the patients who are going for surgical procedure to manage ectopic or a miscarriage. Okay. In these conditions, the anti-D dose is not required. If it is solely medical management for ectopic or miscarriage, if it's a threatened miscarriage, or if it's a complete miscarriage without any surgical thing, or the patient has pregnancy of unknown location. So in these four things, you do not need to give anti-D.
Okay.
And in that anti-D lecture, I also told you that up to 20 weeks, you do not perform Fleury-Betke test to quantify the fetal-maternal hemorrhage. So because it's early, first trimester only, so you need not do a Fleury-Betke test. Okay.
Okay.
Then, according to the talk, this 2021 talk, how do you manage pregnancy? Suppose you do a scan, you don't find a sac or a fetal pole. Okay, so that is pregnancy of unknown location. You are not able to see a GSAC. Okay, so that is pregnancy of then how do you manage the patient? So what all you can think? Probably it could be miscarriage or failed pregnancy, or it could be an ectopic pregnancy. Yes, two things can happen, right?
Yeah.
So how do you manage? So first you see how are the vitals of the patient. Does the patient have pain? If the patient is stable and she is pain free, then you just do beta HCG monitoring. You monitor beta HCG every 48 hours. Okay. So you do it at the baseline when she comes and then you repeat it after 48 hours. This is about if the patient is stable and pain free. If the patient is unstable and has pain, then you have to think of ectopic and you have to immediately proceed to laparoscopy or laparotomy. Okay. If the patient is stable but has pain, then you assess them clinically and you decide whether you have to, based on the beta HCG values and all, whether you have to consider laparoscopy or not. Okay,
Okay.
understood. So you have to take two serum HCG measurements. If it's a like patient is stable, pain free, then you have to take two serum HCG measurements as near as possible to 48 hours apart, but no earlier to determine the subsequent management. And how does the further management depend on? So based on the two values, you correlate. This was the older thing and this is the newer thing. Like according to the NICE guideline, they have changed the value. So if you see the two values, there is more than 13% decrease, because when you will be solving the questions, no, sometimes they give the older things. So you might get confused. So I just put both of them so that you don't get confused.
Okay.
Okay, so in older talk, they had said that if there is more than 13 percent decrease, then it is a failed pregnancy. Okay, so that pregnancy will not continue. Okay. In the newer one, they have reduced this value to 50% decrease to call it as failed pregnancy. Okay.
Okay.
So if it's a failed pregnancy, you just ask them to do a urine pregnancy test in 2 weeks. If UPT comes out to be positive, ask them to do a beta HCG. Okay.
Okay.
And this was if it was more than 13% or more than 50% decrease according to the latest one. If it is less than 13% decrease or less than 50% decrease according to the latest one, that means it could be any of these. Either it could be a pregnancy of unknown location or possible ectopic. So then in that case, you have to repeat an HCG on day 7. You again repeat a beta HCG on day 7 of the cycle and see. Okay.
Okay.
Then if the beta HCG is increasing and it is more than 63% increase, then it's a normal intrauterine pregnancy. Then you ask them to get a scan done after 7 days on day 7. Okay. And if it is less than 16% increase, again it can be an ectopic pregnancy. So they have to repeat scan on day 7 when HCG is expected to be more than 1000 because that's when the sac is visible. Understood? This table is clear?
Yes, ma'am.
Okay. So for a woman with an increase in HCG greater than, this is the latest guideline, NICE 2019. Actually, you will have your questions on this. This I put because you might get confused when you are solving the older recalls. You might come across these percentages, so I put it here. But mostly you will get questions on the latest percentages only. So for a woman with an increase in serum HCG greater than 63% after 48 hours, inform that she is likely to have a developing intrauterine pregnancy, although the possibility of ectopic pregnancy cannot be excluded. Offer a transvaginal scan to determine the location of the pregnancy between 7 and 14 days later. Consider an earlier scan for a woman with serum HCG greater than 1500 international units. Okay. So you just ask them to get a repeat scan 7 to 14 days. If after that viable pregnancy is confirmed, then obviously she goes for routine follow up. If a viable pregnancy is not confirmed, then you have to refer to senior gynecologist for further review because we have to find out. Although the HCG is increasing, but we are not able to localize the pregnancy. You have to localize where the pregnancy is actually localized. So you refer them to senior gynecologist. Okay.
Okay.
Then for a woman with decrease in HCG more than 50% after 48 hours, then you have to tell them that they are unlikely to continue. The pregnancy is unlikely to continue, but this is not confirmed, and provide her with oral and written information about that she can access support. Ask her to do, in this case, you have to tell them to do a UPT after 14 days. If the test is negative, then no further action. If the test is positive, then you have to refer them to early pregnancy assessment services for clinical review within 24 hours. So that means it could be ectopic. Okay. So that's why they
Okay.
have to return to emergency to just rule out where the pregnancy is. Okay. So it is simple. Like if the fall is more than 63, if the rise is more than 63%, it is an intrauterine pregnancy. You possibly an intrauterine pregnancy. So you do a scan after 7 to 14 days. If you confirm after the scan there is intrauterine, you continue. Otherwise, thinking of ectopic, you refer them to senior gynecologist. And if the fall is more than 50%, initially you will think that it is a non-viable pregnancy. So you just do a UPT after 14 days. If it is negative, then it is well and good. If it is positive, then you have to refer them to emergency services. Okay.
Okay, ma'am.
For a woman with decrease in serum HCG levels less than 50% or an increase less than 63%, refer to clinical review for clinical review in early pregnancy assessment services within 24 hours. So this you get. So they can give you a scenario like this patient comes to today her beta HCG level is this after after 48 hours when you repeat there is 48% decrease in the level. So what will be your next step? So next step will be you have to review ask the patient to review in the early pregnancy assessment service within 24 hours. This is how questions are asked. So you have to know what you will do next. Understood?
Yes, ma'am.
Yes, ma'am.
Okay. Then coming over to the RPL GTG guideline. So what is recurrent miscarriage? So miscarriage basically is defined as spontaneous loss of pregnancy before the fetus reaches viability. And according to UK guidelines, they have defined viability is until 24 weeks of gestation. Okay.
Okay.
And recurrent miscarriage is defined as, according to the RCOG GTG guideline, it is loss of three or more consecutive pregnancy, and it affects 1% of the couples. Okay.
Okay, ma'am.
Then about the risk factors, so advancing age is an important maternal age, and number of previous miscarriage are two important independent risk factors for recurrent miscarriage, and these percentages are very important. So this is something also which you should remember because it has been asked. So up like 12 to 19 years, the risk of miscarriage is 13%. 20 to 24, it is 11%. 25 to 29 it is 12, 30 to 34 it is 15%, 35 to 39 it is 25%, 40 to 44% years it is 51% risk of miscarriage, and more than 45 years 93%. Okay, years of age, like the it also depends on the this was about the maternal age, it also depends on the age of the father as well. Okay. Then, advanced maternal age has also been identified as a risk factor for miscarriage. The risk of miscarriage is highest among the couples where the woman is more than 35 years and the man is more than equal to 40 years. Previous reproductive history is an independent predictor of future pregnancy outcome. Risk of further miscarriage increases after each successive pregnancy loss, reaching approximately 40%. This percentage is important. They ask you, like, the patient has already had three consecutive miscarriage. What is the risk of miscarriage in subsequent pregnancy? Then your answer will be 40%. Or they ask you that patient is 40 years of age. What is the risk of miscarriage? It's around 51%. Okay, so these percentages are asked in your exam. A previous live birth does not prevent women for developing recurrent miscarriage. Then one of the important cause of recurrent miscarriage is APLA. So it is the most important treatable cause of recurrent miscarriage. And this is also important. APLA are present in 15% of the women with recurrent miscarriage and less than 2% of the women with low risk obstetric history. So 15% have recurrent miscarriage. So you check it only if the patient has RTL, and the live birth and pregnancies with no pharmacological intervention. Like if you don't for apply, how do you manage these patients? You give them ecosprin and LMWH during the pregnancy. Okay.
Okay.
So if you don't treat them, then they have the live birth rate is very low. It is around 10% only. Understood?
Okay.
Then how do you define APLA? So all women with recurrent first trimester miscarriage and all women with one or more second trimester miscarriage should be screened before pregnancy for APLA. Okay, so there is a Shapiro criteria diagnosis of APLA where one clinical criteria and one lab criteria should be present. Clinical criteria include vascular thrombosis or pregnancy morbidity. Pregnancy morbidity can be death of a normal fetus, like if there is one abortion more than equal to 10 weeks, or a premature birth at less than 34 weeks due to any placenta related complications like preeclampsia, or more than equal to three consecutive abortions at less than 10 weeks, or if there is placental insufficiency at less than 34 weeks. So these are the clinical criteria. Lab criteria, you check three antibodies. One is anti-cardiolipin antibody, anti-beta 2 glycoprotein antibody, and lupus anticoagulant. So these two values you check, and if the titers are over 40 gram per liter or ml per liter or above the 99 centile, and that is considered to be diagnostic, and you need two values. It has to be two values 12 weeks apart for the diagnosis. So you need one clinical and one lab criteria for diagnosis of APLA.
Okay.
Understood?
Yes, yes, ma'am.
So if the patient is APLA positive, then you have to give them low dose aspirin plus heparin to prevent further miscarriage. And here there is no role of giving corticosteroids or intravenous immunoglobulin therapy. Okay.
Okay.
Then another cause of RPL is inherited thrombophilia. So it could be because of activated protein C resistance. Most common of these is factor V laden mutation, or if there is deficiency of protein C or protein S and antithrombin 3, and or hyperhomocystinemia and prothrombin gene mutation. So these are the various causes of inherited thrombophilia, and it has also been implicated as a cause of recurrent miscarriage and late pregnancy complications, with a presumed mechanism being thrombosis. It causes basically thrombosis in the uteroplacental circulation, causes compromised blood flow to the baby, and hence causes abortion. Okay, so women with second trimester miscarriage should be screened for these inherited thrombophilias like factor V laden, factor 2, gene mutation, and protein C. So only for second trimester miscarriages you will be screening them for these two, these inherited thrombophilia. Then there are genetic factors. So genetic could be parental chromosomal rearrangement. So it has been seen in 2 to 5% of patients with recurrent miscarriage, and there could be balanced structural chromosomal anomaly. Most commonly is the reciprocal or Robertsonian translocation. So this percentage is also important, that how much percentage is associated with chromosomal anomaly. So it is 2 to 5%. Or in majority of the cases with recurrent miscarriage, there is embryonic chromosomal abnormalities, which account for 30 to 50%, 57% of the further miscarriages. And the risk of miscarriage resulting from chromosomal abnormalities of the embryo increases with the advancing maternal age. Okay.
Okay.
Then cytogenic, like if the patient had miscarriage, then you can, how do you diagnose for this? You can send the products of conception for cytogenic analysis to look for these chromosomal anomalies in case there is recurrent miscarriage. So this you can do, or you can do, if the products of conception are not available, then you can do parental peripheral blood karyotyping of both the partners when with recurrent miscarriage, where testing of the products of conception reports an unbalanced structural chromosomal anomaly. So either you do cytogenic analysis, and then if it is not available, you do karyotyping, or if there is any problem in the products of conception, then you do again a karyotype of both the partners. Okay.
Okay.
This is about the genetic causes. Then there are anatomical causes. Anatomical causes could be congenital uterine malformations or cervical weakness. Congenital uterine malformations, the reported prevalence is around 1.8, between 1.8 and 37.6%. And it has been reported that women with arcuate uterus tend to miscarry more in second trimester, while women with septate uteri are more likely to miscarry in the first trimester. So arcuate is more likely associated with second trimester miscarriage, and septate is most likely associated with first trimester miscarriage. So this was about the congenital anomalies. Then cervical weakness is another cause of second trimester miscarriage, and the diagnosis is usually based on the history of second trimester miscarriage preceded by spontaneous rupture of membrane or painless cervical dilatation. Okay, so in these cases, you can put a cerclage. So for anatomical factors, all women with recurrent miscarriage, how do you diagnose? And all women with one or more second trimester miscarriage. So they should have an ultrasound for pelvic anatomy to rule out any anatomical causes like uterine malformation. And if there is suspected uterine anomalies, then you have to further investigate them using hysteroscopy, laparoscopy, or 3D ultrasound. Okay, so this was about the diagnosis and management. And in women with singleton pregnancy and a history of one second trimester miscarriage attributable to the cervical factors, an ultrasound indicated cerclage you can do. Okay, the cervical length is less than 25 mm before 24 weeks of gestation. So this I also told you while we were discussing about the cerclage in the last lecture, right?
Okay.
So for like the if there is recurrent first trimester or at least one or two second trimester miscarriage, first you have to look for anatomical problems. How do you do? You do a pelvic ultrasound. If you see anything abnormal, you do hysteroscopy, laparoscopy, or 3D ultrasound and manage it accordingly. And for cervical weakness during the pregnancy, you start screening them for the cervical length. If they have history of these painless cervical dilatation, all that, you start screening them. And if you find that cervical length during the screening is less than 2.5 centimeter, you put a surplarge. Okay, this was about it. Then other factors which are associated with RPL is endocrine factors. So systemic maternal endocrine disorders such as diabetes and thyroid are also associated with miscarriage. So, however, the well-controlled diabetes is not a risk factor for recurrent miscarriage, nor if it's treated thyroid function. So, as you diagnose thyroid and sugar diabetes, you should treat them. So, when they are controlled, the sugar is under control and thyroid is under control, it is not a risk factor for recurrent miscarriage. Anti-thyroid antibodies have also been linked to recurrent miscarriage. PCOS has also been linked to an increased risk of miscarriage, but the exact mechanism remains unclear. The increased risk of miscarriage in women with PCOS has been recently attributed to insulin resistance, hyperinsulinemia, and hyperandrogenemia. An elevated free androgen index appears to be a prognostic factor for subsequent miscarriage in women with recurrent miscarriage. So PCOS is also a risk factor. So you should ask the patient to, before they're trying to conceive, to adopt lifestyle modifications. However, it has been seen giving them metformin and all doesn't help, or anti-androgens generally doesn't help. In fact, anti-androgens, so you should not give them during pregnancy. Okay, so these are the endocrine factors associated with recurrent miscarriage. Then there are certain immune factors also. So there are two types of immune responses, Th2 and Th1. Th2 is anti-inflammatory response and Th1 is pro-inflammatory response. So in pregnancy, usually the Th2 response predominates. Okay, and in case it is the Th1 response which is predominating, it can result in recurrent miscarriage. Okay.
Okay.
So this is the gist of this slide. So there is no clear evidence of to support the hypothesis of HLA incompatibility between couples, the absence of maternal leukocytotoxic antibodies or absence of maternal blocking antibodies. However, they should not be routinely offered. So they should not, hence they should not be routinely offered as an investigation. You should not test for these HLA. You should not do HLA typing or maternal leukocytotoxic antibodies or maternal blocking antibodies. All these you should not do. Then there are two types of NK cells. One, it is the peripheral NK cells, and the other one is uterine NK cells. So it has been seen that there is no clear evidence that altered peripheral NK cells are related to recurrent miscarriage. So you should not check for these NK cells. Even for uterine NK cells, although it has shown that they have a role in trophoblastic invasion and angiogenesis, in addition to being an important component of local maternal immune response to pathogens. So they have a role in trophoblastic invasion and angiogenesis and implantation. But it has been seen, and it has also been seen that uterine NK cells in women with recurrent miscarriage was not associated with an increased risk of miscarriage. Okay, so it has not been associated with the evidence that we have. It has not been associated with the miscarriage. So you should not test for either uterine NK cells or peripheral NK cells for while you are managing these patients for recurrent miscarriage. So testing is not required for them. Then about the Th1 and Th2 response. So cytokine responses are generally characterized either as Th1 with the production of pro-inflammatory cytokines like interleukin-2, interferon, tumor necrosis factor, TNF-alpha, or Th2 response where there are anti-inflammatory cytokines like interleukin-4, 6, and 10. It has been seen that normal pregnancy might be a result of predominantly Th2 where anti-inflammatory cytokine response, whereas women with recurrent miscarriage have a bias towards mounting a Th1 response. So pregnancy, usually this is something which is asked in pregnancy, it is a Th2 anti-inflammatory response which predominates. However, outside pregnancy, it is like if there is recurrent miscarriage, it is the Th1 response which predominates. Okay, any doubts till now?
Yes, ma'am.
Yeah, can ask.
No, like after you finish the topic, I'll ask.
Okay, okay.
Have you completed? Not yet, right?
No, no.
You please complete it.
Okay. Then in about these things, do these things have a role in recurrent miscarriage? So there is insufficient evidence for following treatment in recurrent pregnancy loss, like progesterone, HCG, metformin, heparin, in thrombophilias other than APLA. So these things you should not give patients routinely for recurrent miscarriage because they have insufficient evidence. Okay. So this was all for today. Any doubts you can ask me now.